Hello everyone, welcome to this video on the anatomy of the pelvic viscera. I thought this would be a fun way to revise and teach this to whoever's interested, and I've made videos on the other parts of the abdomen and pelvic region, which you may find useful to watch if you haven't already. You can find the series in order in a playlist that I've linked down below. I'm using my notes based on my university's anatomy guide and some pictures taken from online if you're interested. And as always, feel free to ask if you have any questions or if you want any links to resources or anything else you've seen in this video. Now, as a disclaimer, just to warn you, because I think this must be in YouTube's terms and conditions somewhere, this video does contain anatomical images of genitalia and pelvic viscera, so if you weren't expecting that, then please click out. Now, let's have a look at the pelvic cavity. So this is an image of the male and female pelvic cavities. We have various spaces formed by a peritoneum, pelvic peritoneum continuous with the abdominal peritoneum, and we have various organs which are different in the male and female. So we both have a bladder and rectum, but the male does not have a uterus and so on, and the female does not have all these organs, so we will take a look at those. Now, the pelvic peritoneum is continuous with that of the abdominal cavity, and it encloses the sigmoid colon to form the sigmoid mesocolon. So this part in this diagram is the sigmoid colon, which is enclosed by its mesentery, which is part of the pelvic peritoneum, not the abdominal peritoneum. There's various spaces and pouches formed by this pelvic peritoneum. So we have the recto-uterine pouch, which is formed in females from the visceral peritoneum. So here we can see, this is a female because you can see the uterus here. So we have the pelvic peritoneum here, and it forms the recto-uterine pouch. See the recto-uterine pouch on this diagram. And it lines the posterior surface of the uterus. You can see here, continues down into the posterior fornix of the vagina, and then it turns backwards onto the anterior part of the rectum. So rectum is here, goes down, posterior wall of the uterus, and turns back up onto the anterior wall, anterior surface of the rectum. And the visco-uterine pouch is between the uterus and the bladder, so the bladder would be somewhere anteriorly here, and then the visco-uterine pouch is between the bladder and the uterus. The retrovesical pouch is formed by the peritoneum, which is reflected from the rectum onto the base and upper part of the bladder. So we can see from the rectum and reflected onto the upper base of the bladder. So this can be a problem because intraperitoneal material like inflammatory exudate collects in the peritoneal pouches easily, so it's prone to infection, and also it's at the most inferior point of the peritoneal cavity, so stuff from above can collect in these spaces, which is important clinically. Now the bladder, the urinary bladder, I should say, is what stores the urine before it's excreted. So we can see the various parts here. This is a male bladder. There's the vas deferens leading to the prostate and the base of the bladder, which adheres to the pelvic floor, the levator ani muscles, and so on. Then we have the ureters going into the bladder, and the urethra coming out of the bladder through the prostate and into the open. We have the seminal vesicles as well, only in the males. So it's an extraperitoneal organ, it's not inside the peritoneum, and it's immediately posterior to the pubic symphysis. You can see the pubic symphysis here. The urinary bladder has a triangular base or trigone, which is adherent to the pelvic floor, so the levator ani muscles. This is the trigone of the urinary bladder, that's base. And the bladder walls are composed of smooth muscle, otherwise known as detrusor muscle, which contracts reflexly when the bladder's full in infants, which is why they can't hold their urine in very well. It's supplied by parasympathetic nerves, so the pelvic splanchnics from S2 to S4 for micturition, which just means urination. So we have the S2 to S4 pelvic nerves supplying the bladder up here, these nerves. Given parasympathetic innervation, and in the male there's sympathetic supply to the neck of the bladder, which is the opening here, and those arise and they're useful for closure during ejaculation so that urine doesn't come out at the same time as semen. And there's postganglionic sympathetic fibers for the bladder which arise in L1 to L2 spinal cord segments. Sorry, I'm messing this up. Preganglionic sympathetic fibers to the bladder which arise in L1 and L2, and then postganglionic fibers which run from the ganglia within the pelvic or hypogastric plexus, which we will have a look at soon. So the blood supply of the bladder, so there's superior and inferior vesical arteries, which are branches of the internal iliac artery. So you can see here the common iliac artery on both sides, and that bifurcates here into the internal and external iliac artery, and the bladder is supplied by branches of the internal iliac artery, the superior and inferior vesical arteries. And in the females, the base of the bladder is supplied by vesical branches from the uterine arteries, which are here. So the uterine arteries, see the uterine artery here as well. So another branch of the internal iliac. The bladder venous drainage, so it drains to the vesical plexus at the base of the bladder. As you can see here, there's vesical plexus, it's a pixelated image. And then it drains into the internal iliac vein. And in the male, there's drainage via the prostatic venous plexus as well. The mucosa of the renal plexus, ureter, bladder, proximal urethra is lined by a special type of epithelium called transitional epithelium, which is a form of stratified epithelium. And this is important because it needs to be able to withstand the toxicity of the urine and accommodate the high degree of stretching in the bladder. The smooth muscle is present at the internal sphincter at the bladder neck where the urethral opening is, and it relaxes when the bladder is full, so it allows the urine to pass through the urethra. The urethral opening of the bladder is at the anteroinferior end of the trigone of the bladder, the base of the bladder. And in the male, the urethra passes through the prostate gland after exiting the bladder first. The seminal collicus, or right, I've got to get this right, verumontanum, is formed by the posterior wall of the prostatic urethra pushing forwards into the urethral lumen. So you can see the posterior wall of the prostatic urethra pushing forwards into this lumen to form this bump here on the back. That's the seminal collicus. And the prostate adds secretions to seminal fluid via ducts opening into the urethra on either side of the collicus. So there would be ducts on either side of this verumontanum. Verumontanum. So you can see another picture of the seminal collicus here, otherwise known as the verumontanum. The ureters enter the bladder at two posterolateral angles, so they sort of cut in from the back and laterally. You can see that. No, we can't see that on this image. They run down the posterior abdominal wall and the posterolateral aspect of the pelvis, and they cross the pelvic brim, so the pelvic inlet, which is the hollow ring here, crosses the pelvic brim at the bifurcation of the common iliac artery, so bifurcating into the internal and external here. That's where the ureters cross the pelvic brim. And they run anteromedially inferior to the vas in the male and the broad ligament and the uterine artery in the female to reach the base of the bladder. And we'll have a look at those structures later. In the female, the ureters run past the ovary. So the ovary here, you can see the ureters run past the ovary posteriorly and inferior to the uterine artery alongside the vaginal fornices. The ureters enter the bladder obliquely, as we saw, and they run through the muscle under the mucosa, creating a flap valve to prevent urine backflow, or visco-uteric reflux. So the ureters enter the bladder obliquely, and there will be a valve here to prevent backflow of urine. The bladder neck is anchored by ligaments, so in the female it's the pubovesical ligament, and in the male it's the puboprostatic ligament. And it anchors the bladder neck to the pelvic floor and the body of the pubis, which is the anterior bone of the pelvis. The prostate secretes fluid and nourishes and protects sperm. That's what its function is. Blood supply is, as you probably guessed, a branch of the internal iliac arteries. So it's the inferior vesical and the middle rectal arteries. Inferior vesical artery and middle rectal artery supplying the prostate here. The rectum, so rectum means straight in Latin. It's not always straight, it can be if we're sitting down. And it commences anterior to S3. It's a continuation of the sigmoid colon here, and it passes downwards in the sacral concavity. It turns forward at the coccyx as the dilated ampulla. So we can see here a better picture of the rectal ampulla, which turns forward at the coccyx here, as a dilated rectal ampulla. After a short course, the rectum bends back sharply through the pelvic diaphragm and the puborectal sling to become the anal canal in the peritoneum. So don't get confused, the anal canal and the rectum are two different parts. The blood supply of the rectum is mainly from the superior rectal artery, which is a continuation of the inferior mesenteric artery, and the middle rectal artery, which is another branch of the internal iliac artery, with additional supply to the muscle wall. So it's got sympathetic and parasympathetic supply. The sympathetic is from the hypogastric plexus, so postganglionic axons arising from the ganglia of the hypogastric plexuses. And here's some information about the hypogastric plexus. So the superior hypogastric plexus lies on the sacral promontory between common iliac arteries, and it's a continuation of the aortic plexus. It's formed by the branches of the third and fourth lumbar sympathetic ganglia and parasympathetic fibers ascending from inferior hypogastric plexus. The superior hypogastric plexus gives branches to these other plexuses, the ureteric, gonadal, and common iliac plexuses, and it divides into the inferior hypogastric plexuses. So there's a right and left inferior hypogastric plexus on either side of the rectum, and each plexus contains sympathetic fibers, which are mainly postganglionic, from superior hypogastric plexus and the sacral sympathetic ganglia, as well as parasympathetic or preganglionic fibers from the pelvic splanchnic nerves. Extensions from the left and right inferior hypogastric plexuses enable the autonomic fibers to be distributed to pelvic viscera, and these extensions are the rectal, vesical, uterovaginal in the female, and prostatic plexuses in the male. So you can see it's hypogastric plexus, continuation of the aortic plexus, and that's how they run here. You can see in this diagram. The celiac plexus has fibers running with the inferior mesenteric and superior rectal arteries, and preganglionic fibers arising from the L1 and L2 spinal cord segments. There's parasympathetic innervation from the pelvic splanchnic nerves S2 to S4. Now, next organ is the testis, suspended in the scrotum on the pedicles of the spermatic cord. So this thing is a spermatic cord, and the testis is inside in the scrotum. It's covered by a tough fibrous tunica albuginea, so it's meant to be covered by a very tough fibrous layer. It's formed from the embryological state by migrating through the inguinal canal. So the spermatic cord is one of the structures inside the inguinal canal. And in the embryo, it migrates through the inguinal canal, drawing the overlying peritoneum with it, forming this sac. You can see the spermatic cord, and then if we open it up, there's the epididymis, which we'll get onto, and the testis inside. The residual connection of the testis to the peritoneal cavity is the obliterated processus vaginalis, and the head of the epididymis. There is definitely a picture of the epididymis here, but we will get onto that later. Is at the upper pole of, here. Sorry, I forgot about that. Epididymis, so that's the head of the epididymis. Is at the upper pole of the testis, and the body lies posteriorly, with a tail continuous with the vas deferens. The blood supply of the testis is from the testicular artery, which goes through the spermatic cord via the branch of the abdominal aorta, so it's a direct branch of the abdominal aorta. Venous drainage is via the pampiniform plexus to the testicular veins. The vein drains into the inferior vena cava on the right and into the left renal vein on the left, which is a common pattern we've seen because the inferior vena cava is on the right side of the midline. Then from the testis drains to the para-aortic nodes, and the nerve supply of the testis is from visceral afferents, which run with the sympathetic efferents derived from the T10 spinal cord segment, and here any pain is referred to the peri-umbilical region. The testis has no parasympathetic supply. The spermatic cord, as we saw here, this is just a cross-section of the spermatic cord. So we have 3 layers of fascia. We have the internal spermatic fascia, the cremasteric fascia, and the external spermatic fascia on the very outside. On the very inside, we have the artery to the vas deferens, and the lymphatics surrounding it. We have the testicular artery, the venous plexus surrounding the testicular artery, and sympathetic fibers as well. And in the cremasteric fascia layer, we have the cremasteric artery accompanied by the genital branch of the genitofemoral nerve, which is a branch of the lumbar plexus. On the very outside layer, don't seem to have anything of importance, and then the ilioinguinal nerve is outside the external spermatic fascia, which is another branch of the lumbar plexus. The vas deferens is something that is in the spermatic cord as well, so we can see the vas deferens here, and it enters the abdominal cavity at the deep inguinal ring, which is where it enters the inguinal canal, and crosses the medial surface of the external iliac vessels and pelvic brim to enter the pelvic cavity. At the posterior superior corner of the bladder, the vas deferens turns medially and runs towards the midline. The vas is dilated posterior to the bladder to form the ampulla of the vas. You can see this dilated bit, that's the ampulla of the vas. And it narrows at the base of the prostate, here, where it unites with these seminal vesicles on the same side to form the ejaculatory duct. 2 ejaculatory ducts pierce the prostate, and they run obliquely through to open into the seminal collicus. The vas deferens has a blood supply from the artery to the vas, which is usually a branch of the superior vesical artery, and it accompanies the vas to the lower pole of the epididymis. The seminal vesicles are supplied by branches of the inferior vesical arteries, and innervation of the intrapelvic vas and seminal vesicles is the same as that of the bladder. So you've got the L1 and L2 and S2 to S4 para and sympathetic, and then you've got innervation of the vas in spermatic cord is the same as that of the testis, so that's around T10 sympathetic and no parasympathetic innervation. Uterus is a very mobile and hollow organ with thick fibromuscular walls. It's a reproductive organ that's only present in the female. And the uterus and tubes are covered on the anterior, superior and posterior surfaces by the visceral peritoneum. So it's covered by peritoneum. At the inferior borders of the tubes and the lateral borders of the body, the anterior and posterior peritoneal layers meet and they fold to form this broad ligament. So it's a double fold of parietal peritoneum at the pelvic floor and the lateral pelvic wall. It forms this broad ligament of the uterus, and the mesovarium attaches the ovary to the posterior layer of the broad ligament. So you can see the mesovarium here. It just attaches the ovary to the posterior layer of the broad ligament. The broad ligament continues lateral to the lateral wall of the pelvis from the mesovarium. So to the lateral wall of the pelvis from the mesovarium. Part of the broad ligament of the ovary is raised as the suspensory ligament of the ovary. So you can see here, the suspensory ligament of the ovary. Oh wait, this is a better picture. Suspensory ligament of the ovary. And it transmits the ovarian vessels and lymphatics. The ligament of the ovary, so on the other side of the ovary, runs from the ovary to the uterus at the level of the uterine tube. So you can see the uterine tube here, and the ligament of the ovary runs from the ovary to the uterus here. Ovary to the uterus. So yeah, and at the level of the uterine tube, it's continuous with the round ligament. So we can see the round ligament here, round ligament of the uterus. And the two ovarian ligaments are the female equivalent of the male gubernaculum. So round ligament, we can see here. The round ligament of the uterus extends from the junction of the uterus and its uterine tube to the labium majus of the vulva. See the round ligament, this, not the blue thing, this green thing here. And it first runs between the layers of the broad ligament and then crosses the pelvic rim to enter the deep inguinal ring, passing through the inguinal canal. The pubocervical ligament fibers pass from the pubis anteriorly around the bladder to the cervix. I should probably show you this picture. So as the various different types of ligaments holding the cervix in place. The pubocervical ligaments pass from the pubis anteriorly around the bladder to the cervix. The cardinal or transverse cervical ligaments, they're connective tissue bands which run in the broad ligament. So inside this double fold of peritoneum, this broad ligament, the transverse cardinal ligaments run in there. From the lateral pelvic wall to the junction of the cervix and the vagina. The uterosacral ligaments run from both sides of the uterine isthmus to the sacrum. So the uterine isthmus to the sacrum. Each uterosacral ligament runs lateral to the rectum here, and raises a visible bridge in the parietal peritoneum. So let's have a look at the uterus now. The uterus is divided into a fundus at the very top. It's a broad upper end covered by peritoneum. And then the body in here, the body of the uterus, where the uterine tubes are attached at the cornua. We have the cervix, which is this opening here, which projects into the vagina, and upper and lower ends of the internal os and external os of the cervix. So internal os, external os of the cervix, and then into the vagina here. Now we have a good picture here as well. We can see there's endometrium lining the inside of the uterus, and myometrium as well, where the muscles are. The uterine body is antiflexed, so antiflexed, meaning that it's inclined forwards anteriorly in relation to the cervix, so this would be anterior and posterior, it's antiflexed. In the majority of women, the lower end of the cervix is invaginated into the anterior wall of the vagina at a right angle. So it's anteverted and anteflexed. So you can see this sort of right angle here. The fornix is a part of the vagina that envelops the cervix, so it's divided into anterior, posterior and lateral fornices. So you can see the fornix is just this part of the vagina that envelops the cervix, the uterus, and it disappears after a short length. The uterus is supplied, unsurprisingly, by the uterine artery with additional supply from the ovarian artery. So uterine artery and ovarian artery here passing to supply the uterus. It passes immediately in the base of the broad ligament to reach the uterus across and above the ureter. The sympathetic supply of the uterus comes from the preganglionic axons originating in T10 to L1 spinal cord segments, and they synapse in the hypogastric plexuses. The parasympathetic innervation comes from the pelvic splanchnic nerves from S2 to S4. The uterine tube is this part of the uterus coming from the fundus or the body and to the ovary. So the uterine tube is divided into several parts. We have the interstitium, which is inside the uterine wall, so it's not technically part of this long tube here. The isthmus, which is the half of the tube which is nearest to the uterus with a very narrow lumen. The ampulla, the dilated part of the uterine tube, which is characterized by gradual widening. And then we have the infundibulum, which widens significantly, opening into the peritoneal cavity. So there's a direct connection between the peritoneal cavity and the outside, really. So, yeah, and then this infundibulum leads to the fimbriae, which are numerous finger-like projections at the distal edge of the infundibulum. They're often seen grasping the ovary, but in actual fact they're not, and they're partially erectile, so they grasp the ovary at the time of the ovulation, and only like one finger grasps the ovary, so it's not the whole thing clasping onto the ovary. The ovary occupies the ovarian fossa on the lateral wall of the pelvis, and the ovarian pain is referred to the peri-umbilical region. You can see the isthmus, ampulla, and the infundibulum. The ureter is immediately behind the ovarian fossa, and the obturator neurovascular bundle is lateral to the ovary. The ovary is supplied by direct branches of the abdominal aorta. We saw the ovarian artery, that's directly from the abdominal aorta, which supplies the ovary and the uterine tube, and anastomoses with the uterine artery. So here you can see a clearer picture here. The uterine artery anastomosing with the ovarian artery. The venous plexus in the mesovarium drains into the ovarian arteries, which accompany the ovarian veins, and the ovarian veins drain into the inferior vena cava on the right and the renal vein on the left. The lymphatic drainage of the ovary is to the para-aortic nodes, and the sympathetic supply of the ovary is from preganglionic axons, which originate in the T10 spinal cord segment. No parasympathetic supply, synapse in the pre-aortic ganglia at the origin of the ovarian artery, so same sympathetic supply as the testis. The internal iliac artery is what supplies the pelvic region and the pelvic viscera. So we've looked at several branches which supply the individual organs, but we can look at the whole thing by itself. So it arises at the bifurcation of the common iliac artery anterior to the sacroiliac joint, the bifurcation here, and it descends on the posterior pelvic wall to the greater sciatic notch, which is a notch in the sciatic foramen in the pelvis. It divides into anterior and posterior trunks, and it gives parietal and visceral branches. So you can have a look at the anterior and posterior trunks. We have parietal and visceral branches. So the visceral branches are the superior and, well, there's no inferior here, but there would be, so superior and inferior vesical arteries, the middle rectal artery and the uterine artery. The parietal branches include the superior and inferior gluteal arteries and the obturator artery and the internal pudendal artery as well. So these are just some of the arteries of the various branches. Obviously, there's quite a lot. In the fetus, the internal iliac artery continues as the umbilical arteries. So these are obliterated in the adult, but in the fetus there's umbilical arteries, and the internal iliac artery is a continuation of this. Continues onto these and descends on the abdominal wall to the umbilicus. It reaches the placenta via the umbilical cord, and after birth the umbilical artery is obliterated into the fibrous cord, which is visible as the medial umbilical ligament. So that's most of the anatomy of the pelvic region. Now let's have a look at some clinical applications of this area. So suprapubic catheterization is required sometimes, and the fully distended bladder rises out of the pelvis into the abdomen, which strips the peritoneum upwards from the anterior abdominal wall. You have to be careful here because extraperitoneal suprapubic puncture could be made into the full bladder if there's urinary retention, so we don't want any leaking there. Now, rectal examination, we've got this lovely picture here which shows a rectal examination, and a digital examination is required for the assessment of the posterior surface of the prostate gland, so you can feel the texture of the prostate gland, and this can be used to diagnose things like cancer. It's anterior to the rectum, the prostate gland, so anterior to the rectum, and you can attempt to feel the seminal vesicles on the back of the bladder here, but it's not often very possible. Vaginal examinations can't be performed on children, but a rectal exam can give some information about the posterior wall of the vagina. In adult women, a rectal examination can provide info about the recto-uterine pouch, and the uterine cervix, as well as the lower part of the body of the uterus. Then we come to rectal cancer, carcinoma of the rectum, which is a common malignancy in the GI tract. The tumour is initially localised to the rectal wall, but if it's not detected and treated, then it's going to expand into the surrounding regions, and this could cause a lot of pain because the posterior extension, so if it extends behind, then that could interfere with the sacral plexus, and that will cause severe pain in the leg because of the distribution of the sciatic nerve, which is a very large nerve that goes into the leg, and any lateral extension might involve the ureter, so we don't want the ureters to be blocked off by this. Anterior extension in the male could involve the prostate, the seminal vesicles, the bladder, or the vagina and the uterus in the female, which would obviously not be good for reproductive organs. Torsion of the testis is rotation of the testis around the spermatic cord within the scrotum. So you can see here this testicle has undergone torsion, as opposed to this normal one. And it's common in children and active young men. And some people say that cycling can increase the risk of this happening. It causes severe pain and it requires emergency surgical treatment because occlusion of this testicular artery in here leads to testicular necrosis. So we need that blood supplied to the testis. Labour pain results from birth, obviously, when women are giving birth to a baby. Sustained uterine contractions can cause very severe labour pain, and the pain is carried along axons running in the same nerves, providing sympathetic supply to the organ, so it reaches the T10 to L1 spinal cord segments. The mild pain can start from cervical distension as the fetus begins its descent. The pain travels along the axons that carry parasympathetic innervation to the uterus and reaches S3 to S4 spinal cord segments, may be referred to the sacral region. Somatic pain of delivery comes from perineal stretching, and the pain is carried by the pudendal nerve. It's possible to eliminate labour and delivery pain by anaesthetising the spinal nerves T10 to S4, and is most popularly it's applied via lumbar epidural block. The skin needs to be tested to ensure that the anaesthesia has worked from T10 to perineal region. And lastly, we have peritoneal infection in women, because as I mentioned before, there's a passageway from the external environment all the way by the vagina, uterus and uterine tube into the peritoneal cavity. And this usually kept closed by the lining of the uterine tube and obviously by the vagina closing up, but there can be a possible route for infection to pass into the peritoneal cavity, so you need to be aware of that. Now that's it for this video. If you enjoyed this, please leave a like, comment, and any feedback or questions down below. Subscribe, and I will see you next time. Whoops. See ya.